The first speaker would be the chairman of the session, Dr. Avnindra Gupta, who is a senior veterinary surgeon from Faridabad and Delhi. And he would be talking about introduction to OCT angiography and kind of interpretation. How do you go step by step on OCT angio?
Thank you, Ritesh. Uh, we'll start our IC and basically first we'll learn what is OCT angiography and how to interpret it. OCTA was first introduced in 2014. It is a new armamentarium in retinal imaging, fast and non-invasive, dye-free angiography with high definition OCT in one machine. Prior to OCTA, FA and ICG were the mainstay modalities to detect any abnormalities in retinovascular visualization. Fluorescein angiography and ICGA generated two-dimensional in-force view of the retinal vasculature. But with advent of OCTA, we are able to demarcate different layer of retina, that is deep superficial layers of the retina and the capillary plexus. The principle involved here is angioplex detects motion of scattering particles. These are RBCs. Within sequential OCT, B scan performed repeatedly at the same location of the eye. Each cluster is acquired in the same position on the retina. Each cluster generates one blood flow scan, and then you get this kind of an angioplex details where you can see different capillaries and blood vessels in the retina. I will be talking mostly about Zeiss Series 6000 because I have that machine and I don't have any financial interest into it. Zeiss uses OMAG microangiography complex. OMAG is an imaging technique which uses the complete complex OCT data signal, including both amplitude and phase. This is the only machine which has phase and amplitude, so the pictures what you get are much better. In OCT, what Dr. Nadal Hussain has told us, you see the cross-section of the retina. Like if you cut and cake like this, you will see the cross-section of the retina and then you can demarcate what are the layers of the retina. But in OCTA, what you see is an in-force image, like what you are seeing, and then you are turning off the pages of the retina one by one. So if you see this video, this we call as a segmentation line, and you will come across this segmentation line again and again. The moment this segmentation you can see different phases here. This is the segmentation line. Once it reaches the choroid RP, you can start seeing the lesion at this level. So what you are doing in OCTA is you are cutting horizontal planes of the retina like this. What you are cutting, not cake vertically, you are cutting the retina horizontally. So like turning the page of the retina, you see superficial plexus, you see deep plexus, avascular zone, you see RP, choroid, and you see an in-force image of the retina. So this is very important. Like if you see, these are the segmentation line. As the line moves, you can see now the choroid and different layers of retina. You can demarcate and you can find the pathology in the retina. This is a small video how OCT angiography pictures are collated. This is a non-invasive dye-free angiography with single scan simplicity. Motion of red blood cells is detected by sequential OCTs performed repeatedly at the same location up to 4 times. Based on the property of the light reflected from RBC, motion is detected and vessels with blood flow are identified. Real-time tracking of eye movement with FASTAC results in motion artifact-free images. Immediately recovers from eye movements and blinks. Angioplex is powered by OMAG algorithms, and then you get full advantage of amplitude phase from OCT, and you can see this is a superficial layer which is marked as red. The deep retinal layer is marked as green. The avascular zone is marked as blue. These are the color codings. Once you read the maps or the reports in the retina, this is the report how it comes, and there are three pictures here at different slab. This is the superficial layer, this is the NFOS images, and this is the B scan pictures, and these red dots are flow in the blood vessels. So we have two types of OCT angio. One is spectral domain and one is swept source. In spectral domain OCT, the wavelength is 840 nanometers, and a spectrometer is used as a detector, while in swept source OCTA, light source is a diode laser with 1050 nanometers, and single photodiode is used as a photodetector. The difference between swept source is fast. It can penetrate more into the retina, so you can get good images of the choroid. But the resolution is higher in spectral domain OCT. Another disadvantage of swept source OCT, the cost is double as compared to a spectral domain OCT. Coming to the interpretation of the OCTA images, there are three images here. One is this NFOS image. This is the structural image, and these are the B-scan images within flow overlay, where you can see what is the flow in the blood vessels. The area of the the area what you want to image is first detected, and then you go ahead and look for the OCTA images. Look at the segmentation line. This is very important because the lesion, where the lesion is, whether it's in the choroid or is in the retina, the segmentation line should be at that plane. Look at the B-scan with flow overlay. This red thing what you see here, these are the flow overlay. This tells what is the flow in this lesion. Like lesions like PCV, where the flow is very minimal, you will not get any flow overlay. And these are the structural images or an infrared images, INFAS images of the retina, how you see the retina. After you have detected, depending on the type of disease what you have, you can design what type of scan you want. If you want to see a macular lesion that is with high resolution, then you should go for a 3x3 or 6x6 images. If you want to see, like in this patient, I want to see a CNVM, so I go for a 3x3 or 6x6 images. The moment I want to see areas of capillary non-perfusion, I'll go for a wider scan, that is 8x8 montage, that gives somewhere around 12x12, or you can go with 12x12 areas. The advantage is you can see here in 12x12, you can see a lot of CNP areas. You can go beyond the arcades and see the areas of capillary non-perfusion or disease pathology in a wider area. But more the scan area, more the time it takes. And the other problem is more artifacts you will get once you have more of the scan area. Look at the INFAS images, and these are the various interfaces or the layers what you detect on OCTA images, superficial retina, deep retina, each of which I'll be discussing in detail in coming slides. So superficial retina slab includes hilum, ganglion cell, and inner plexiform layer. In this layer, you see superficial capillary plexus, and you can see the FSZ here. This is normal here. But many times in diabetic branch vein occlusions, you can see irregular FSZ that can explain you why the vision is less in many of the patients. Although you might not have good edema, but you will have this kind of capillary dropouts explaining why the vision is less. Deep capillary plexus extends from inner nuclear layer. The outer plexiform layer includes intermediate and deep capillary plexus. OCTA is the only clinically available imaging modality that can visualize these two capillary plexus. One is deep capillary plexus and intermediate capillary plexus. Intermediate capillary plexus can only be defined in machines with Heidelberg. Other Topcon machines, Zeiss machines, cannot diagnose intermediate capillary plexus. Outer retinal slab extends from the outer plexiform layer, the outer nuclear layer. This slab is avascular, so any vasculature in this layer denotes a pathology like MNB. Choriocapillary slab is defined as 20 micron slab below the retinal pigment epithelium. Much like the avascular slab, the choriocapillary slab should be evaluated in AMD and other pathologies associated with MNV. Here, what you can see here, there is an choriocapillary. You can see a nice CNVM complex here in the choriocapillaries. In this image, what you can see here, this is an pigment epithelial detachment, and you can see that segmentation line we have used an RP fit. And segmentation line automatically goes and marks the pigment epithelial detachment, and this takes care of projection artifacts. And here, what you can see here at this, there is an polyp. This is one of the patient you can see here has a subretinal hemorrhage. There is an CSR-like serous detachment at the posterior pole. Once we do an fluorescein angiography, you can see a leak here, and there is an polyp-like thing within the pigment epithelial detachment which leaks. See, these images are fluorescein angiography images. If you go on to see an OCTA images of this patient, how much wealth of information you will get. But you will have to do a proper segmentation. You can see here the pigment epithelial detachment. It's just looking like a kidney shape, and there is a notch. So if you have a notch PD, the diagnosis is clear that is an occult CNVM. Here, if you do a segmentation here, you can see an BVN, branching vascular network, that confirms the diagnosis, yes, it's an PCV lesion. And if I go for an RP fit, you can see here there is a polyp here. So we get a wealth of diagnosis, but your segmentation should be proper to come to a diagnosis. ORCC slab is combination of outer retinal choriocapillaries. It was first described by Rosenfield et al. The slab spans from outer plexiform layer, the outer nuclear layer. The choriocapillaries can be used to screening slab of type 1, type 2, and type 3 CNVs. You can see this is ORCC slab. You can see a nice CNV complex here. Another patient, you can see a very good CNV complex in these patients. Choroidal slab displays a slab which is 50 micron slice posterior to the choriocapillaries. Differences in wavelength and light source leads to variable detection of choroidal vasculature. And if you use a wide scan, you can see whether the vessels are Pachy vessels or normal vessels, and any pathology in the choroid can be detected by this. Again and again, I am stressing the importance of segmentation line. Many a times, if you don't do a proper segmentation, you will not get proper information on OCTA. Like in this patient, you have a lot of projection artifacts, and I have done a manual segmentation. On manual segmentation, you can see here on structural OCT, there is a pigment epithelial detachment. On this margins, you can see here, there is an BVN. Here again, I have done a segmentation in a case of pigment epithelial detachment with subretinal hemorrhage. And once I do a segmentation, you can see here, I have done a segmentation. It's passing in between the sub-RP space. And you can see here, there are multiple polyps here, giving us a diagnosis, yes, it's in PCV. And many a times, I can tell you I have left fluorescein angiography in my macular patients. I only do OCT to come to an OCTA to come to a diagnosis. B-scan overlay is a two-dimensional projection of three-dimensional structure of the retina. In-face image should be therefore always be interpreted in context of the corresponding B-scan. Like this, you have a membrane here. So to see the flow here, you have to see these green dots here, which are the choroidal vasculature. So you know ki what you are seeing is corresponding to the blood flow. So you can correlate, yes, you are looking at the right structural deformity. InFOS many a times with like in this patient, you are not able to detect an NVD or NVE. So I look at an InFOS image here, you can see an fibrovascular proliferation. So all three pictures in an OCTA should be interpreted. You can also compare the previous disease pattern with a new disease pattern. You can see here, this is an CNV, and we have done, patient was on anti-VEGF therapy. There was a slight fluid on B scan. And over it, I gave a gap of 3 months, and you can see the CNV has reduced, it has increased, and the fluid has increased. So this gives us an information that you should continue with anti-VEGF therapy in this patient. This is a very interesting patient. You can see a CNV here. This was on anti-VEGF therapy for 2 years down the line. And after 2 years, you can, this on 6 weekly therapy. And after 2 years, you can see here the MNV or the CNV has disappeared. So you get wealth of information on OCTA. All three images, InFAS OCTA images with structural images and B scan with flow overlay should be assessed for the correct diagnosis. In doubt, always sit in the machine for correct segmentation and B scan overlays. It is evolving technology with lot to learn every year. Thank you very much for.
Thank you, Dr. Gupta, for such a comprehensive talk on basics of OCT angiography and the slabs and importance of segmentation and overlays. Any questions from the audience?
So world over, Anand, what's your experience with macular diseases? With peripheral diseases, still OCTA is not the treatment of choice, but with macular diseases, what is your line of treatment, whether you go only for OCTA or you combine OCTA with fluorescein angiography?
Yeah, I think in this day and age, the OCTA acquisition, as you also demonstrated, with the higher end spectral domain as well as the new generation swept source is so fast, it doesn't give you a lot of downtime. So when the patient is sitting along with structural OCT, along with autofluorescence, you can get an OCTA very fast with, as you mentioned, any kind of macular disease. There's always going to be bang for that buck. And as I'll also show in my presentation, not just is it macular distortion, but also that macular FAZ enlargement is also seen. So you're actually also picking up any progressive macular ischemia that may be developing in the course of your disease. Sometimes that can also tell you whether there will be, visual acuity improvement. So sometimes underlying macular ischemia is also picked up, yeah. Absolutely. It can actually empowers us to even pick up preclinical diabetic retinopathy changes.